Evaluation of left ventricular systolic function is Lecture 1 in the Practice of Cardiac Sonography 2 unit. The contents of the lecture include 1. The cardiac cycle, 2. Cardiac output, 3. Qualitative assessment, and 4. Quantitative assessments. The learning outcomes. Following this lecture, you will be able to discuss the physiology of left ventricular systolic function, explain the advantages and limitations of different measurements of LV systolic function, and apply different techniques to measure LV systolic function. Chapter 6 of the textbook of clinical echocardiography and Chapter 4 of essential echocardiography are chapters you'll need to refer to for more information. Firstly, the cardiac cycle. The heart is the driving force of the circulation. The heart muscle is made up of cardiac myocytes, which perform the mechanical action of the heart. Each myocyte is filled with long, protein-rich myofilaments that are arranged in parallel. The thin and thick actin and myosin filaments interact with each other in alternating periods of contraction and relaxation. The term used to describe the events that occur from one heartbeat to the next is the cardiac cycle. Systole is a Greek word that refers to the period of the cardiac cycle during which the heart contracts. Both the atria and ventricles have systolic phases. In a heart beating at 70 beats per minute, atrial systole lasts about 0.1 of a second and occurs prior to ventricular systole. Ventricular systole normally lasts around 0.3 of a second. Diastole is another Greek word, and it refers to the period of the cardiac cycle during which the heart relaxes. Both the atria and ventricles have diastolic phases. Ventricular diastole normally lasts for about half a second. The synchronous, rhythmic, mechanical action of myocytes enables the heart to perform its normal function, that of pumping blood around the body. This action occurs as a result of coordinated electrical stimulus starting at the sinoatrial node. Blood flow occurs when pressure within a chamber forces one of the heart valves to close and another to open. Normally, blood flow within the heart is antegrade, which means forward moving. Most often, when one uses the term systole, the point of reference is the contraction of the ventricles. As this lecture is about evaluating left ventricular systolic function, when I use the term systole, I'll be referring to LV contraction. Going deeper, systole is defined as the phase of the cardiac cycle from mitral valve closure to aortic valve closure. The mitral valve closes when LV pressure exceeds LA pressure. This is immediately followed by isovolumetric contraction, when the myofilaments begin to shorten and the LV pressure rises rapidly. When LV pressure exceeds aortic pressure, the aortic valve opens and the ejection phase begins. Initially, the ejection of blood occurs rapidly. Then towards the end of the ejection phase, it occurs more slowly. An LV pressure volume loop is another way of showing how pressure and volume change during the cardiac cycle. Again, concentrating on events during systole. The mitral valve closes when LV pressure exceeds LA pressure. This is followed by isovolumetric contraction when the LV contracts and pressure rises rapidly, although initially in this phase, LV pressure is still less than aortic pressure. When the LV pressure exceeds aortic pressure, the aortic valve opens and the ejection phase begins. Again, the ejection phase initially starts with rapid ejection, and then towards the end of the phase, it occurs more slowly until the aortic valve closes again. Using echo images, isovolumetric contraction time is the brief period following mitral valve closure when the LV muscle starts to contract, but LV pressure is yet to exceed aortic pressure, and the aortic valve is yet to open. The ejection phase, when the aortic valve is open and LV pressure exceeds aortic pressure, can be clearly seen using color Doppler. Cardiac output. The volume of blood ejected by the heart per minute is termed the cardiac output. It is the product of heart rate and stroke volume. With pulse wave Doppler and an ECG, cardiac output can be estimated with echo. That is, by measuring left ventricular outflow, VTI, LV stroke volume can be estimated. And when this is combined with the heart rate, the cardiac output can be determined, which in the example on this slide works out to be about 5.4 litres per minute. At rest, cardiac output is between 5 and 6 litres per minute normally. This can increase up to 5 times with strenuous exercise. As mentioned, an increase or a reduction in cardiac output is a product of the heart rate and stroke volume. Factors that influence heart rate include the autonomic nervous system, fitness, gender, and age. Normally, an increase in heart rate from rest results in an increase in cardiac output. But cardiac output is also dependent on stroke volume, and stroke volume is determined by several factors. Firstly, myocardial contractility. It influences stroke volume. When LV myocytes contract, pressure within the LV chamber increases. The myocytes, which are arranged in different orientations, work to pump the blood from the LV. Obviously, damage to myocytes reduces their contractility and reduces the stroke volume. Another factor that influences stroke volume is preload. Preload refers to the blood volume in the LV prior to contraction. Normally, an increase in volume prior to contraction, which stretches the myocytes, results in a more forceful contraction. This is in keeping with the Frank-Starling law that states that increased LV end diastolic volume increases LV stroke volume. And afterload. Stroke volume is also influenced by afterload, which is related to the resistance to blood flow. Hypertension and aortic stenosis result in increased afterload and mean that more pressure must be generated by the LV in order to maintain stroke volume. Qualitative assessment. Overall, the LV is normally somewhat cone-shaped. Its constituent myocytes are arranged in different orientations, and the net effect is that when it contracts, it has longitudinal, circumferential, radial, and twisting motions. Qualitative assessment provides an estimate of LV radial thickening and apex to base longitudinal shortening based on the appearance of the images. Qualitative assessment is best when multiple imaging planes are used. Both global and regional LV systolic function can be evaluated. Qualitative assessment is often used in stress echocardiography, where baseline, that is pre-stress images, are compared with peak or post-stress images. Normally, post-stress, radial thickening should increase, longitudinal shortening should increase, but chamber size should reduce. The main advantage of qualitative assessment is that it's fast. The disadvantages include the fact that it's subjective in nature. It's dependent on experience and on 2D image quality. Quantitative assessment. Quantitative evaluation provides assessment of LV systolic function based on measurement of images. The guidelines on chamber quantification from the American and European associations indicate that quantification of cardiac chamber size and function is the cornerstone of cardiac imaging, echocardiography being the most commonly used non-invasive imaging method in cardiology. In this final part of the lecture, we'll carefully review 4 ways of making quantitative analysis of LV systolic function by echo. Firstly, linear dimensions by the M-mode method. By measuring the internal dimensions at end diastole and end systole, a fractional shortening measurement is made. That is, fractional shortening is a measure of the fractional change in the internal diameter of the LV. Once measurements have been made with the calipers, the ultrasound machine calculates the fractional shortening using the equation on this slide. M-mode has high temporal resolution, and if this measurement is performed carefully, it's highly reproducible. A major disadvantage of M-mode is that the measurement may be made at an oblique angle to the long axis of the LV, and if so, systolic function is underestimated. Moreover, as M-mode uses a single line of sight, it's unreliable if the geometry of the LV is abnormal or in the presence of wall motion abnormalities. To ensure the most accurate fractional shortening measurement by M-mode, aim to align the cursor perpendicular to the long axis of the LV. Measure the internal dimensions using the trailing edge to leading edge technique at the level of the mitral valve leaflet tips. End diastolic and end systolic measurements are made when the LV is its largest and smallest, respectively. Linear dimensions measured with 2D. Again, by measuring the internal dimensions at end diastole and end systole, a fractional shortening measurement can be made and is calculated automatically by the machine using the equation on the slide. Two advantages of making this measurement by 2D are that it is fast and can be made in most patients. The disadvantages are that it's a measure of basal function only, and it's inaccurate in the presence of regional wall motion abnormalities. To ensure the most accurate fractional shortening measurement by 2D, aim to align the calipers perpendicular to the long axis of the LV. Measure the internal dimensions at the mitral leaflet tips, observing the point of black to white interface End diastolic and end systolic measurements are made when the LV is its largest and smallest, respectively. 2D LV volumes and ejection fraction. LV volumetric measurements by 2D are made by tracing the interface between the compacted myocardium and the LV cavity. Usually, this is done by starting at the septal mitral annulus and working around to the lateral mitral annulus. At the level of the mitral valve, a straight line is used to connect the opposite sections of the mitral ring, and the LV length is measured from the center of the line across the mitral annulus to the most, or to the point of the LV apical contour. LV volumes should be measured from the apical 4 and the apical 2 chamber views. Frame rate should be maximized and foreshortening avoided. Depth reduced images help to ensure an accurate trace of the compacted myocardium. The Simpson's biplane method of discs is the recommended method for calculating volumes. LV ejection fraction is calculated from end diastolic and end systolic volumes using the formula shown on this slide. To ensure the most accurate ejection fraction measurement by 2D, aim to optimize your 2D image, paying particular attention to endocardial definition and frame rate. Reduce the depth displayed to ensure a more accurate tracing. Avoid image foreshortening. Ideally aim for a window from a lower rather than a higher rib space. Measure the compacted myocardium starting at the septal mitral annulus and working your way round to the lateral mitral annulus, and exclude the pap muscles. The line at the level of the mitral annulus should be close to horizontal, and the LV length should be measured up to the contour at the apex. Normal ranges and severity partition cutoffs for LVEF are shown on this slide. More ranges are part of the course reference values document, which I encourage you to use. Myocardial mechanics. Tissue Doppler allows the measurement of myocardial motion from specific sites. The most frequent sites are the LV septal and lateral walls at the level of the mitral annulus. The velocity of myocardial movement is measured in centimeters per second. In systole, the myocardium moves toward the apex. The point where the systolic velocity is highest is termed S'. As tissue Doppler is a Doppler technique, it's important to try to ensure parallel alignment between the beam and the longitudinal motion of the heart. A sample volume of 3 to 5 millimeters should be placed at the level of the mitral annulus for septal and lateral measurements, and the brightest point where the waveform peaks should be identified and measured. In conclusion, systole is the phase of the cardiac cycle where myocytes contract. It's during systole that blood is ejected from the LV through the aortic valve into the aorta and systemic circulation. Cardiac output, measured in litres per minute, is the product of heart rate and stroke volume, which are influenced by various factors. Qualitative assessment provides an estimate of LV systolic function based on the appearance of the images. Quantitative assessment provides evaluation of LV systolic function based on the measurement of images.